Hello, and welcome to this mini-series from the MDTea Podcast team, covering some of the more common issues encountered when working with older adults. Each session is structured around a clinical question, and our aim is to help you approach the issues like a geriatrician. The best part is they're all only around 10 minutes long. I'm Alice O'Connor, and I am joined remotely by...
Hi, I'm Ian Wilkinson. I'm a consultant geriatrician down at East Surrey Hospital.
I'm Jo Preston. I'm a geriatrician in South West London.
And this session is all about bone health. You can see how remote we are by the delay.
So, Mrs. Smallbone has fallen over and fractured both her pubic rami and one of her vertebrae. She's been seen by my consultant and she's definitely for conservative management, and we wondered if she ought to be moved to a care of the elderly ward.
So as geriatricians, this is something that we get referrals like this really quite frequently. And whether the answer to that is yes or no depends quite a lot about how your geriatrics team is set up and how much support they provide to the orthogeriatrics team. So they may take over care, or they may only get involved if there are other unresolved medical issues around the fracture that need specialist input. But fear not. Here are 5 things that you can easily do for any older adult who's had a fracture.
Number 1 is pain relief. We sometimes get so caught up thinking about the management of fractures that we forget that they hurt. And if somebody's unable to move properly because of the pain, then their recovery is going to be delayed.
Number 2, check the serum calcium and vitamin D levels. These got important implications for diagnosis and treatment of osteoporosis. It's also important to check their renal function, thyroid function, and maybe their vitamin B12 levels as well.
Number 3, you've identified someone that's already fallen. It's worth looking at whether they've got further falls or fracture risks. We're going to go on to tell you a little bit more about assessing fracture risk in later this episode.
And number 4 is a physio assessment. So older people with almost any fracture will need to be seen by a physio. So it's really important to get the MDT involved early on. This can be done on surgical and orthopaedic wards. So the idea that people need to go to a care of the elderly ward for MDT input is a myth.
Number 5, once you've calculated the fracture risk, you might want to go on and start some medication to reduce this. And we'll go over drug treatment a little bit more at the end of this session.
So osteoporosis is a disease causing reduced bone mass and deterioration of the bone structure as well, making the bones more brittle and prone to fracture. So bone health depends on a balance between the action of osteoblasts, which build up the bone, and osteoclasts, which cut away the bone. This balance is maintained by the parathyroid hormone even, and vitamin D.
Vitamin D deficiency also causes a reduced bone mass, or reduced bone density rather, and that's called osteomalacia. Bone density also reduces with age, especially in postmenopausal women.
Osteoporosis causes around 9 million fragility fractures worldwide each year. A fragility fracture is where a bone breaks when it shouldn't. So you might expect somebody to break bones falling down a flight of stairs, but a low impact fall shouldn't lead to a large bone fracture. So for example, a fall from standing height causing a vertebral or hip fracture. Fragility fractures cause significant morbidity due to pain and disability, and hip and vertebral fractures are associated with reduced life expectancy.
Theoretically, someone's fracture risk is the sum of their bone density, their falls risk or the frequency of their falls, and the force of the falls that they're having. However, in practice, this is difficult to calculate, but you want to think about those 3 elements. As part of a thorough assessment, you should be thinking about fracture risk in any men over the age of 75 and any women over the age of about 65.
And this is especially true for anyone with a history of falls, anyone with previous fragility fractures, a family history of a hip fracture, anyone who's on long-term or frequent steroid use, or any known cause of secondary osteoporosis, such as Cushing's, celiac, or hyperparathyroidism.
There are a few tools that you can use to quantify someone's fracture risk. So one is the FRAX score, which is available online from Sheffield University. This is aimed at medical professionals, really, and it gives you the option of entering the patient's bone mineral density score if you know it. The fracture risk is reported along with a recommended action to take, which might include sending the patient for a bone scan to find out what their bone mineral density is. Just bear in mind that they need to be able to get onto a table and lie still if they're going to have a bone scan. The Q fracture score is quite easy for patients to do themselves, and the results are presented in a layperson-friendly format, showing their risk of having a fracture over the next 10 years.
Before jumping straight to medications, though, it's important to think about lifestyle measures that someone can take to improve their bone health. So you can reduce alcohol intake. Alcohol is toxic for the bones. You can stop smoking and make sure that there's enough weight-bearing exercise and calcium in their diet. There's a dietary calcium calculator that's available online, and we'll put a link to this in the notes. Patients can do it themselves if they've got internet access. It's quite detailed though, and they probably need to keep a food diary for a week or two beforehand to do it really accurately.
So we would advise that people take regular load-bearing exercise. So that doesn't include things like swimming or cycling, when they're not putting weight through their bones. But just as we wouldn't ask physiotherapists to prescribe medications, we can't just prescribe an exercise program without knowing really what that person can do. So you need to get a physiotherapist to do an assessment to help you. They'll do things like check someone's posture, their existing muscle strength and balance, as well as their level of pain and functional ability to participate in exercises, to be able to come up with an exercise program which is appropriate for that person, as well as the injury that they've sustained as well.
And strength and balance training has been shown to reduce the risk of falls, which indirectly reduces the risk of fractures. Resistance training has shown to be good for sarcopenia, which is low muscle mass, as well as for osteoporosis itself.
Then the Royal Osteoporosis Society has issued guidance on exercise. And in summary, the advice is that people with osteoporosis should do more rather than less physical activity. The benefits of doing exercise outweigh the potential risks, and that people who have painful vertebral fractures should be given prompt advice on how to adapt their movements for activities of daily living, and also exercises to improve posture and pain.
So when starting any medications for osteoporosis, it's really important to check their calcium and their vitamin D are replete first, otherwise they're just not going to work. An initial treatment of choice is usually an oral bisphosphonate, so something like rositronate or alendronic acid. And these reduce osteoclast activity, so the cells that cut away the bone.
Adherence to these medications is not great and it's quite variable, with around 50% of people stopping taking them after a year to two. And that's usually due to the GI side effects. These can be improved by following administration guidelines closely. And so any patients started on oral bisphosphonates should be followed up to check on this.
So both rositronate and alendronic acid need to be taken regularly, weekly, at least weekly, for about 3 years in order to work. So if someone's not tolerating them or they're not able to take them, then it might be worth thinking about switching them to an intravenous bisphosphonate instead. So something like zoledronic acid can be given yearly and can sometimes avoid those GI side effects that might limit people's ability to take it orally.
Although that said, once people have been taking the medication for a year, their fracture risk is about 50% reduced than if they're not been taking it.
So beyond that, the options include things like denosumab, which is a totally different medication. It's a monoclonal antibody that inhibits the osteoclast formation and function. Things like teriparatide, which is essentially parathyroid hormone, which has quite strict criteria for when you might use that. And those two options usually require some input from someone with a specialist interest in bone health, and that might be a geriatrician, but it's often a rheumatologist before they can be started, and for monitoring going forwards as well.
So in the notes below this video, we've included links to the various resources we've mentioned, such as the dietary calcium calculator and the fracture risk scores. We've also done a full-length podcast episode on bone health, which you can find on our website, www.hearingaidpodcasts.org.uk. And the MDTea podcast and learning resources are all free to use, and they cover a wide range of topics concerning older people, from safe exercise to safeguarding.
And also check out the rest of this mini-series for some more bite-sized learning. We hope this episode of Help has been a help. Bye-bye.
Bye.